Percutaneous coronary intervention is an invasive but non-surgical technique that is performed within 90 minutes of an acute MI. It combines clot retrieval, coronary angioplasty, and stent placement. Stents are expandable metal mesh devices that are used to maintain a patent lumen created by angioplasty or atherectomy. Patients who undergo percutaneous coronary intervention are required to take dual antiplatelet therapy consisting of aspirin and a platelet inhibitor. Before the procedure, the patient receives an initial dose of a platelet inhibitor such as clopidogrel and aspirin. Administration of an oral platelet inhibitor is required after the infusion. If there are any concerns that the patient may require coronary artery bypass graft, the platelet inhibitor may be held until after the procedure. The inhibition of platelets is permanent and increases the risk for post-op bleeding. Patients should wait 5 to 7 days before undergoing a coronary artery bypass graft after taking a platelet inhibitor. If the patient has received thrombolytic therapy, clopidogrel is the preferred drug. During the procedure, the patient may receive boluses of IV heparin or a continuous infusion of bivalirudin. Heparin is used to maintain an elevated activated clotting time and prevent clotting on wires and catheters during the procedure. It is discontinued before removal of catheters. Bivalirudin is a direct thrombin inhibitor and is frequently used as an alternative to glycoprotein platelet inhibitors and heparin. IV or intracoronary nitroglycerin and diltiazem is given to prevent coronary vasospasms. PCI initially reopens the vessel in most patients. However, within the first 24 hours, a small percentage of patients have restenosis. At 6 months, a large number have one or more blockages. The healthcare provider also prescribes a long-term nitrate and beta blocker, and an ACE inhibitor or ARB is added for patients who have had primary angioplasty after an MI. Some patients may experience hypokalemia after the procedure and require careful monitoring and potassium supplements. After PCI, monitor for potential problems, including acute closure of the vessel causing chest pain and potential ST elevation on a 12-lead ECG, bleeding from the insertion site, and reaction to contrast medium used in angiography. Also monitor for and document hypotension, hypokalemia, and dysrhythmias. Document and report any of these findings to the healthcare provider or rapid response team immediately. Other techniques being used to ensure continued patency of the vessel are laser angioplasty and atherectomy. Atherectomy devices can excise and retrieve plaque or emulsify it. One of the advantages of this procedure is that it creates a less bulky vessel with better elastic recoil. Another procedure that may be performed is rheolytic thrombectomy, which uses low-pressure, high-speed saline jets to break up the clot. Injecting vascular endothelial growth factor during angioplasty has increased perfusion to the wall of the heart. Also, vascular endothelial growth factor helps initiate new blood vessel growth and development, which results in increased blood supply to cardiac muscle.